Let's discuss Chapter 58 in your Iggy book, Care of Patients with Liver Problems. More than 30 million people in the U.S. have liver disease. That's 1 in 10 Americans. 4 million Americans have hepatitis C, and more than 1 million have hepatitis B. Combined, the incidence of chronic liver disease and cirrhosis are the 12th most common cause of death in the U.S. So my point in starting this lecture with that is that this is all very important, and you absolutely in your nursing career will come into contact with people who have issues with their liver. One of our biggest issues with the liver is cirrhosis. Cirrhosis is extensive, irreversible scarring of the liver, and it's usually due to chronic inflammation. It develops slowly and is progressive and usually ends in end-stage liver disease. In the U.S., the most common causes of cirrhosis are chronic alcoholism, chronic viral hepatitis, non-alcoholic steatohepatitis, or NASH, bile duct disease, and genetic disease. As far as the pathophysiology of cirrhosis, it is widespread scarring. There are these bands of fibrotic or scarred, hardened tissue that change the liver's normal makeup. Inflammation is caused by toxins or disease, and it results in the destruction of hepatocytes. That's just liver cells. Hepat is liver, cyte is cell. So destruction of liver cells. As the cirrhosis develops, the cells become nodular and kind of ball-like, and the nodes can block the bile ducts and blood flow. Initially, in the early stages of cirrhosis, the liver is enlarged, firm, and hard, but as the disease progresses, the liver ends up shrinking and decreases in decreased liver function results. This can take place over weeks or years, depending on the type of cirrhosis we're talking about. Types of cirrhosis are post-necrotic cirrhosis, and that's caused by viral hepatitis, usually hepatitis C, and drugs or toxins. Alcoholic cirrhosis is another type. Biliary cirrhosis is also called cholestatic cirrhosis, and it's caused by chronic biliary obstruction or autoimmune diseases. Some of the complications of cirrhosis, they depend on the amount of damage that has been sustained. In compensated cirrhosis, the liver is scarred, but it still functions. In decompensated cirrhosis, the liver is totally compromised, and we are seeing obvious signs of liver failure. So some of the complications are portal hypertension, which is a persistent increase in pressure of the portal vein greater than 5 millimeters of mercury, and this results when the blood meets resistance to the flow of blood into the portal vein. So the portal vein trying to come into the liver is meeting resistance. It's probably from the cirrhosis, the inflammation, the sclerosis of the liver, it's meeting resistance. So then the blood flow backs up into the spleen and causes splenomegaly. It also causes the veins in the esophagus, the stomach, the intestines, the abdomen, and the rectum to become dilated, and this is where varices come in. Portal hypertension can result in ascites, esophageal varices, prominent abdominal veins, and that's called caput medusae. I'm sure you've probably seen photos of that on abdomens that are rotund with ascites, and you can see what looks like snakes coming out usually of the umbilicus. So the caput is head, medusae of Medusa, so head of Medusa, like snakes from Medusa's head. Hemorrhoids are also a result of portal hypertension. Ascites is one of the complications of cirrhosis, and that is a collection of free fluid within the peritoneal cavity caused by osmotic fluid shift from the vasculature into the abdomen. And it's because of the increased hydrostatic pressure from portal hypertension. So it's essentially third spacing. So this is one of those interesting contradictions, because a person can be hypovolemic because all of the fluid is in the peritoneum, but have edema at the same time. So the volume is not where it's supposed to be. Massive ascites can cause renal vasoconstriction, triggering the renin-angiotensin system, causing sodium and water retention, which then leads to more ascites. So lots of issues with ascites. Esophageal varices, we kind of already talked about in portal hypertension. Because of the portal hypertension and ascites, blood backs up from the liver and enters the esophageal and gastric veins. And these are super fragile. You know that the anatomy of veins is that they're kind of flimsy because they don't have to usually take as much pressure as arteries do. So these fragile esophageal veins become distended because of the pressure, and can eventually end up rupturing and bleeding. Bleeding of esophageal varices is life-threatening because of hypovolemic shock. We discussed all of the blood that comes through the liver. So if we all of a sudden have a backup of this blood under this super high pressure, we're going to see significant blood loss, potentially with esophageal varices. Bleeding manifests as hematemesis, so vomiting blood, or melena, which is that dark blood from the rectum, that dark stool. It can occur spontaneously, but we often will see it with increases in intra-abdominal pressure, like if someone is sneezing or coughing or straining for a stool, and also if they're eating dry, hard food and it gets caught in the esophagus or kind of almost scratches those fragile varices. Portal hypertensive gastropathy, which is a slow gastric mucosal bleeding, and that can result in chronic slow blood loss. Splenomegaly results from the backup of blood into the spleen, and that enlarged spleen ends up destroying platelets, and so that increases our bleeding risk. Oftentimes, thrombocytopenia is the first sign that a patient has liver dysfunction, and this could be one of the reasons why. Biliary obstruction can happen because of cirrhosis, and so the production of bile in the liver is decreased when we have cirrhosis, and this prevents the absorption of fat-soluble vitamins like vitamin K, which is also going to increase a patient's susceptibility to bleeding and bruising. Jaundice, which is that yellow coloring of the skin due to either hepatocellular disease or intrahepatic obstruction, like a biliary obstruction. One of the big symptoms that we see of jaundice is that people get really itchy. Hepatic encephalopathy, or PSE, which is portal systemic encephalopathy, is probably the most disturbing complication of cirrhosis that people see because it affects people's mood and their personality. It's a complex cognitive syndrome, and it includes sleep disturbance, mood disturbance, mental status change, speech problems, like I said, personality disturbances. It might be reversible if there's early intervention, but in late stage cirrhosis, this can include an altered level of consciousness, impaired thinking, and neuromuscular problems. It's thought that hepatic encephalopathy is caused by elevated serum ammonia, but there's other aspects of encephalopathy as well. Page 1194 in your 8th edition discusses what puts patient at high risk for hepatic encephalopathy, including a high protein diet, infection, hypovolemia, hypokalemia, drugs, GI bleeds, and constipation. The last thing I'm going to talk about as far as complications of cirrhosis go is hepatorenal syndrome, and that generally is end stage, and it indicates a really poor prognosis in patients who have liver failure. At this point, we're going to probably see oliguria and an elevated BUN and creatinine. Let's quick touch on the etiology of cirrhosis. We're going to discuss hepatitis in more detail later on in this chapter, but hepatitis C is the second leading cause of cirrhosis and liver failure in the U.S., and alcohol is the first. B and D are the most common cause of cirrhosis worldwide. Non-alcoholic fatty liver disease is a growing concern in the U.S. because it's associated with obesity, diabetes mellitus 2, and metabolic syndrome. It's the most common cause of liver disease in the world and can eventually progress to liver cancer, cirrhosis, or liver failure. It is estimated that at this time 25% of Americans might have non-alcoholic fatty liver disease. Alcohol is directly toxic to hepatocytes and causes inflammation. The liver becomes enlarged and infiltrated by fat and leukocytes and lymphocytes. The good thing about this is if alcohol intake stops, the fatty infiltration and inflammation are reversible. And alcohol is not the only thing that can do this. Other illicit drugs like cocaine have the same effect.